Thank you, Doreen. So Dr. Alex Chapman is a professor and clinical science area coordinator in the Department of Psychology at Simon Fraser University. Dr. Chapman is a registered psychologist and the president of the DBT Center of Vancouver. He received his PhD in clinical psychology from Idaho State University following an internship at Duke. He completed a 2-year postdoctoral fellowship with Dr. Marshall Land at the University of Washington. Dr. Chapman directs the Personality and Emotion Research Laboratory at the Simon Fraser University, where he studies the role of emotion regulation in BPD, self-harm, impulsivity, and other behavioral problems. He has published numerous scientific articles and chapters on these and other topics, and has given many scientific conference presentations on his research. Dr. Chapman has received as well the Young Investigator Award of the National Alliance for BPD in 2007, the Canadian Psychological Association's Early Career Scientist Practitioner Awards in 2011, a Career Investigator Award from the Michael Smith Foundation for Health Research, and the Dean's Medal for Academic Excellence at Simon Fraser University. He has also been practicing Zen and mindfulness meditation for several years. Dr. Chapman enjoyed cooking, hiking, skiing, and spending time with his family. And he shared with us today that he's going to be doing pizza for his family tonight. So without further ado, let's hear Dr. Chapman on understanding emotional dysregulation in BPD.
Great, thank you, Lynn, and it's a pleasure to be here. I'm just going to share my screen and make sure everything works okay here. Let's see here. Okay, can you guys see the slide? Yes, okay. All right, great. So we'll get started. So it's nice to hear that so many people were interested in attending this talk, and this is one of the first few talks that I've given from my home office since this whole thing began, and I hope you are all keeping well and healthy during this very weird period in all of our lives. And it's nice to be able to work from home, but of course there are some challenges. And if you hear any emotion dysregulation in the form of screaming kids in the background, just do your best to ignore it and be mindful as we go forward, as I will be doing the same, which is one reason why I'm wearing noise-canceling headphones. I wasn't going for the Princess Leia look. That's not what what's happening here. It's just noise-canceling headphones. All right, so I'm happy to talk about emotion dysregulation and borderline personality disorder. Of course, some of my favorite topics. And so I want to start off by just talking about how borderline personality disorder is fundamentally a disorder of instability, sort of instability in many different areas of life, whether it's instability in relationships, instability in emotions, behavior, difficulty sort of getting yourself to do things, kind of difficulty with self-directiveness and self-regulation. So instability can show up in lots of different ways, and it can drive family members crazy. Sometimes the instability shows up in the form of something that, of course, I've experienced with my adolescent boys is like progress. Like they seem to be like, we have a really good conversation about something. They seem to really be going in the right direction. We have a plan, everything sounds good. And then the very next day, what? I never agreed to do that. That's not what I'm going to do. And so you all might notice that with some of your family members. There's this also instability in the ability to kind of like move forward and take care of yourself, make plans, stay on the path to recovery and so forth. And so for those of many of you, I imagine, are quite familiar with what the symptoms are of BPD, but there are 5 main areas. And so one is identity problems. So people with BPD often suffer from difficulty understanding who they are and a sort of an unstable sense of themselves. And they might feel completely different, like a different person, depending on what they're doing and who they're interacting with. And that often goes along with a sense of emptiness. Another area is difficulty managing impulsive behavior. So people with BPD often have a really hard time stopping themselves from doing things that are impulsive or that are going to get them in trouble or that are self-damaging, like self-harm behavior or risky sex or reckless driving, other reckless behaviors. Relationship instability, this is something that has a couple of different parts to it. So one is people with BPD often have difficulty with the sense that people might be moving away from them or abandoning them or not being there for them. And then they often compensate for that by trying to hold on really tight to relationships. So efforts to avoid abandonment. And then another part of relationship instability is this sense of like having a love-hate relationship with people. Sort of sometimes it's like you're God's gift to me as a family member or a loved one, and that other times they can't stand you and they hate you and they think you're evil, and sort of going back and forth in that way. Sometimes that happens in therapy with people with BPD. At times they might be saying one week, well, that was the best session ever, you're helping me so much, I'm getting better. And then the next week, I want to quit. So that happens not only in close interpersonal relationships with loved ones, but also with professionals sometimes. People with BPD often sometimes have difficulty thinking when they're upset. So they either sort of space out or dissociate just a little bit, or more severely, or they might become especially suspicious, start wondering about other people's motives, or thinking that they're thinking about them, or talking about them in a negative way, and that kind of thing. And then emotional instability, which we think is really kind of the core of BPD, is this difficulty managing emotions, emotional lability, easily triggered emotions that sort of go up and down, dramatically shifting from positive to negative on a regular basis. And so there are technically 9 symptoms of BPD, but they fall pretty well into these 5 different categories. It's important for the community at large to recognize that BPD is a serious mental health problem. It's not just something that makes people difficult to treat sometimes. It's not just a personality trait. It's a serious mental health problem that has serious consequences. And so here are some of the statistics on suicide and self-injury among people with BPD. And so there's around an 8 to 10% death by suicide rate. My apologies for the wording there. The word commit suicide the phrase commit suicide is out. And so it should read suicide mortality or death by suicide. 69 to 80% of people engage in self-harm, and around 75% have attempted suicide. And you can also see from the graphs there that among inpatients who are in psychiatric inpatient care, people with BPD make up somewhere between 15 and 35% of those people. And so they make up a big chunk of people who are hospitalized for psychiatric reasons. And in terms of people who actually end up dying by suicide, up to 38% of people who end up dying by suicide may meet criteria for BPD. So it's a serious mental health problem that we really have to pay attention to. It also comes with a lot of extra, shall we say, baggage. And I like this one because I'm somebody who never checks my bags when I fly places. I'm not even sure if I'm ever going to fly anywhere anymore now that this whole virus thing has changed things so much. It sounds like flying would be an even worse and more distressing experience than it already was after 9/11. And so as an aside, in the past, I generally have said, no, I never check my bags. And then of course, every year they seem to be making the slots where they measure whether your bags are small enough to be a carry-on smaller and smaller and smaller. And so one year I showed up at the airport and I had my bag and we thought it was small enough, but it turns out it wasn't. And so the woman said, well, you've got to check your bag and you're gonna have to pay for it. And at the time I was thinking, well, what DBT interpersonal skills can I use here? But the only thing I could come up with was the broken record strategy, which basically led to me saying over and over again, I don't check my bags. Turns out that strategy doesn't work with flight people who want you to check their bags, and I had to check them and pay for it. But I digress. So the reason I had that up there was that people with BPD also often struggle with a variety of additional co-occurring disorders. And these co-occurring disorders can range from mood disorders to eating disorders, trauma-related disorders, anxiety disorders, substance use problems, and you can see the statistics there. So people who help people with BPD including support people, loved ones, therapists, clinicians of other sorts, social workers, psychiatrists. They have to know about these other disorders as well. They can't just know about BPD, they also have to know about major depression, substance use problems, eating disorders, and so forth. Because oftentimes these problems come along with BPD, or clinicians will get blindsided. They'll be treating somebody and then all of a sudden they'll discover the person has an eating disorder or a serious substance use disorder that they've been hiding or something. One thing that's important to remember is that BPD is not a life sentence. It's not like this scar you can never remove or tattoo that you can't get rid of. It's something that actually does change over time. And in some ways, BPD might be a more hopeful diagnosis than some other diagnoses. Even something like major depressive disorder, it just keeps coming back, generally speaking. If you are somebody who's had one major depressive episode, you're 80% likely to have another one. And people on average have somewhere between 4 and 6 episodes of depression that are 20 weeks or longer. And so even though depression is very treatable, it's something that keeps coming back. Bipolar disorder is something that's hard to treat or manage without medication. And so is schizophrenia, of course. And so BPD actually has a hopeful prognosis in many ways. So these are some of the stats on how BPD tends to change over time. And this was from a large study conducted by Mary Zanarini and her group. And so they had a large number of people with BPD come into the hospital. And then when they left the hospital, they kept coming back every 2 years for assessments to see whether they still had BPD and what other problems they had. And over the course of 6 years or so, around 70% of them had gone for at least a 2-year period without meeting criteria for the diagnosis for BPD. That's what we mean when we say remission. When it got to 10 years, they were looking at around 80%. And by 16 years, in the upper 90% of people had actually not met criteria for BPD for at least a 2-year period. A smaller number of people were considered recovered. So in order to recover, you had to no longer meet criteria for BPD and you had to have good social functioning. And so you can see that the numbers are smaller for people who have actually recovered. Once you get around 16 years, we're looking at above 50%. But that's still pretty good. It's still it's still hopeful, and it still goes against this message that somehow BPD is part of you and you can never get rid of it. Something that people will always certain people will always have to manage to some degree though. So it's important to remember that just not meeting criteria for the diagnosis doesn't mean that you have no problems or that you don't have any of the tendencies that go along with BPD, like being a very emotional person, for example. And so some of the problems that tend to persist are problems with being highly emotional, having difficulty sort of feeling alienated from other people, difficulties in relationships, negative thoughts about yourself, negative thoughts about other people. There's sort of like interpersonal suspiciousness. Those types of problems tend to persist, tend to hang on, and tend to be things that people have to continue to work on over time. So as far as what actually leads to or causes BPD, it's still something that we're looking at, and lots of researchers are paying attention to lots of different types of causes for BPD, whether they're social, environmental, biological. Right now, what we think is that social factors and biological factors probably work together to lead to emotion dysregulation, which is basically difficulty managing your emotions. And then along the road, eventually lead to the full symptoms of BPD. So according to Linehan's biosocial theory of BPD, which is what forms the basis for the treatment that's called dialectical behavior therapy, some of the biological parts of BPD might include a vulnerability to emotions. So this tendency to be just a more emotional person than maybe other people are. And so this emotion vulnerability comes with 3 different parts. And so one part is, and you can all think of yourselves, think about whether you would check off the box for each one of these parts of emotion vulnerability. So one would be emotion sensitivity, meaning, are you somebody who tends to react emotionally to a lot of different stuff. So is it not very hard for you to start feeling an emotion of some kind? Your emotions tend to be kind of easily triggered. And I never used to think I was especially sensitive until I had kids. And then after that, I became a lot more sensitive. And to the point where I think it was the other night, we even though our kids are adolescents and we thought that they would totally find this show to be dated, we've been starting to watch Star Trek: The Next Generation with them because it's one of our all-time favorite shows. And so we were watching that episode where Data actually makes a daughter, but unfortunately she doesn't survive. And at the end of the episode, it's quite sad. And I'm sitting there and tears are coming down my face. And then the boys are like, all right, what are we doing next? And so their time will come for being emotionally sensitive, but it seems that my time has come. And so emotional sensitivity. And then the next one is emotional reactivity, which is that your emotions tend to be really strong when they happen. And so you're somebody who has very intense emotions. And it doesn't have to be for all emotions. It could be that you feel really intense anger, but you don't feel really intense sadness, or vice versa. But the basic idea is that you're an emotionally intense person. And then the next one is slow recovery or difficulty returning to baseline, which means if you think of baseline emotional experience as something that you would feel if you were just kind of sitting and calmly reading a book or something. So where you don't feel particularly emotional one way or another. And so slow return to baseline means that once your emotions get activated, they have a hard time coming back down again. And the thing about slow return to baseline that's important to remember is that a lot of people think that people with BPD just kind of fly off the handle over small things. But what I think actually is that what's happening is that they're sort of chronically emotionally vulnerable, because when they have a stressful event happen, like they have an argument with somebody and then they go back to their regular everyday activities. Like, let's say, well, these days people aren't socializing so much face to face. So let's say you have an argument with a family member over Zoom and they tell you how you're totally unsupportive and they don't even know why they're talking to you anymore. And then you go back and it's time for you to go make dinner or something, and your emotions are still buzzing at like an intensity of 80 out of 100. Then somebody comes in and says, well, why are you using that kind of cheese for the pizza? I really prefer the other. And then you get all mad at them because your emotions were already so high. But let's say you were somebody who comes back down quickly to baseline. You were at 80 and you went back down to 30 by the time you were making dinner, and somebody criticizes the cheese you're using, you might just take it in stride, no problem. But if you're a person who's slow return to baseline, then you might seem to be overreacting to small things when actually you were already upset and you couldn't come back down again. So that's emotion vulnerability, emotional sensitivity, reactivity, slow return to baseline. Another factor that a lot of people that's getting a lot of attention these days that might be a biological component is trait impulsivity. So people who just have the tendency to be more on the impulsive side. They don't think too much before they act. They tend to favor short-term rewards over long-term benefits. So they're likely to take short-term risks, or if, for example, the classic marshmallow test, where if the kid is able to avoid eating the marshmallow in front of them, then he's able to have more later on. Well, the kid who eats the marshmallow right away is the kid who's impulsive. And they've certainly found that early impulsivity predicts later impulsivity, that impulsivity is highly heritable. And so if you're impulsive, it may be likely that the people who gave you your genes are impulsive. And so impulsivity also makes it hard to raise kids. So impulsive kids have behavioral problems and sometimes, and they tend to be harder to manage. So the vulnerable child who eventually develops BPD is probably both impulsive and very emotional. And so I kind of think of them as, talk about this high emotionality and high impulsivity as kind of like being almost like a fighter jet. So if you're a kid who's highly emotional and highly impulsive, then your task in life is to try and learn how to fly a fighter jet. It's got a powerful engine, it's got lots of different controls, it's very intricate, very difficult to manage, takes a lot of training. And whereas other kids who are not very emotional and not very impulsive, they just have to learn to drive a Volkswagen. And so a lot of the clients that I've seen have said, well, why is it so hard for me? Why do I have to learn all these skills and all this kind of thing? And my answer is usually something along the lines of, you actually have to learn how to fly a fighter jet, whereas other people don't. And it's a bummer because it's a lot harder, but it's also a lot cooler. And I mean, let's face it, if you said, well, I'm a fighter pilot versus I drive a Volkswagen to the grocery store, which sounds cooler? It's just a lot harder, and you need to learn a lot more skills in order to fly that jet. So the emotion vulnerability has lots of different parts and can come in lots of different forms. So the thing about being emotionally vulnerable and being impulsive is that you almost need super parents in order to get by. It's difficult to manage the behavior that goes along with impulsive kids. It's difficult to manage the emotional outbursts. And even really skilled parents will sometimes fall apart at times. So this brings me to the invalidating environment. So the other part, what we call the social or environmental part of the theory, is that being raised in an environment where it just might not be a good fit for you. You're a highly emotional, highly impulsive kid, and this makes it harder to manage your behavior, harder to manage your emotions, harder to sort of teach you the things that other kids learn more easily. Or if you're in an environment that is more extreme, where you're being abused or traumatized, or something in between, so neglect and that type of thing, then you might be more likely or more vulnerable to developing emotion dysregulation and BPD eventually. And so the invalidating environment can come with 3 different parts, and many others as well, of course, including abuse and trauma. But one part is that the environment may reject or criticize the child for experiencing or expressing strong emotions or thoughts. And so if you grow up and you're regularly getting the message that somehow you're wrong, or there's something wrong with you for feeling what you're feeling, then you might start questioning whether you're really feeling it or whether you should be feeling it, and start judging yourself for your own emotions, or starting to avoid or start to suppress or avoid them. The other part is that sometimes the environment oversimplifies how easy it is to solve problems. So it might convey that, well, these problems are easier to solve than you think they are, when the experience of the really emotional and impulsive kid is that their problems are big, powerful, complex, and very difficult to solve. And so it's a lot like sort of saying, all right, well, you just got to get in the cockpit and turn it on and just go for it. Well, it takes a lot more than just that, and it's hard to recognize that sometimes. And then the third part is intermittent reinforcement of emotional escalation. So this means that every once in a while, when the kid gets really emotionally and really intense, the caregivers or other people might give them what they want, sort of like giving a kid what he wants or she wants when they tantrum. So you go to a grocery store, and you've got your son with you, and he just had a big ice cream cone and he's asking for another one, and you say no, and then he starts flipping out and taking stuff off the shelves and rolling around on the floor, making a big scene in the grocery store. Well, you don't want to reinforce the tantrum, like make it more likely to happen in the future by giving the kid the ice cream cone. And so, being somebody who wants to teach your kid not to tantrum, you hold off and you sort of ride it out, and then you bring them home, try to teach them a lesson about it and stuff like that. But then next time you're tired, you've had a really difficult time with somebody, on like a loved one told you on Zoom that you were totally unsupportive, you haven't gone back down to baseline, and you just give in and give the ice cream. And then every once in a while this happens. Well, what happens is that the kid's brain starts to learn, all right, well, this could be the time, and so I better tantrum because this could be the time that I get something for it. So over time, what this does is kids might learn, well, every once in a while I get what I need when I'm really intense. And so they go from like 0 to 60 really quickly. A lot of you might have loved ones who do this. You start talking to them about something difficult, having some difficult conversation with them about something like me having a conversation with my son about screen time or something like that. And they seem to start calm, and then they just, like that, their face is red, they start to get really intense, and it becomes impossible to keep having a conversation with them because their emotions are so high. This is another look at how we think emotion dysregulation and BPD developed. This is sort of like a new version of the biosocial theory, and that has a little more emphasis on this idea of the kid being impulsive. And so the idea is that you may go from being an impulsive kid, and just being an impulsive kid makes you vulnerable to developing all sorts of problems: ADHD, oppositional defiant disorder, conduct disorder, disruptive mood regulation disorder. But being impulsive also makes you more vulnerable to adverse childhood experiences. And it doesn't just have to be in experiences with parents. It could be experiences with peers, siblings, other people, or this poor environment fit that I mentioned earlier. So adverse childhood experiences have a bigger effect on you if you're an impulsive kid. There's some research on this. And then you're more likely to develop emotion dysregulation, difficulty understanding and managing your emotions. Being impulsive on its own also makes you more likely to associate with other peers who are impulsive, who do stuff to cope with their emotions that tend to be problematic, like drug use and alcohol use and conduct problems and all that kind of thing, and self-harm. And so once all of these factors sort of start coming together, self-harm is something that tends to emerge in early to mid-adolescence. And self-harm itself is a high predictor of whether you're going to end up having BPD. And so this is kind of a snapshot of the newer version of the biosocial developmental model. And some of you with loved ones with BPD might have actually watched this unfold over time. Now, it is very complicated, the question of like why people with BPD develop their problems. But it's also very simple in some ways. This is one of my all-time favorite Far Side cartoons. So donning his new canine decoder, Professor Schwartzman becomes the first human being on Earth to hear what barking dogs are actually saying. And all they're saying is, hey, nothing terribly profound. And so we've got lots of complex theories and models about people with BPD. But ultimately, what we think is that the reason that they do some of the stuff that they do that leads them astray, like self-harm, drug use, problems with relationships, outbursts, unable to keep a job, those types of things, they actually do a lot of those things because they work in some way to either manage extreme emotions that they have that a lot of other people don't have, or to get the kind of support that they need from other people. And so it's understandable that they've developed the problems they have, because some of the problems that they have actually work for them, although they cause more problems in the future. The other thing about theorizing about people is that it only sort of takes you so far. And so this is a nice little story I found from, if you're looking for where it came from, it was from a book by a person named Anthony DeMello. And the book's name is The Song of the Bird. And so a dervish was sitting peacefully by a river when a passerby saw the bare back of his neck and yielded to the temptation to give it a resounding whack. He was full of wonder at the sound his hand had made on the fleshy neck, but the dervish, smarting with pain, got up to hit him back. Wait a minute, said the aggressor. You can hit me if you wish, but first answer this question. Was the sound of the whack produced by my hand or by the back of your neck? Said the dervish, answer that yourself. My pain won't allow me to theorize. You can afford to do so because you don't feel what I feel. And so sometimes I think we spend a lot of time thinking and theorizing and all that about people who have serious problems like BPD. And what we might want to spend more time doing is listening to them and trying to understand from their perspective how they're experiencing their problems. So that brings me to treatment, because treatment, of course, is partly a process of listening to people and figuring out how to help them solve their problems. So treatment works for many people. And so this is another hopeful message about BPD. In general, when you look at people with BPD and the effect of treatment, age is not associated with the effectiveness of treatment. So turns out you can teach an old dog new tricks, that even if you're a little on the older side, there's no evidence so far that if you have BPD, that treatment's not going to work as well. And actually, in the psychotherapy literature more broadly, age is a small positive predictor of treatment outcome, meaning that the older you are, generally, the better you do. people with more severe problems sometimes actually experience more change. So people with BPD who have more serious and more frequent self-harm, have more serious BPD symptoms, actually tend to show more change in these areas. They're not always necessarily more likely to completely stop self-harming or to completely not meet criteria for the disorder anymore, but the magnitude of change that they show tends to be bigger. People with PTSD sometimes have worse outcomes, but sometimes do not. And there are treatments now that are developing that are developing in particular to help people with BPD and PTSD that are very promising. And what the findings show that if you treat the PTSD, oftentimes the BPD related problems go down as well. Having a positive alliance with your therapist, in that having a positive working relationship with your therapist is a good thing. This is kind of a no-brainer. If you don't have a good relationship with your therapist, it's going to be very difficult to benefit from therapy. And so this predicts change as well. So if you're thinking for your loved ones, what's important about a therapist? Well, a therapist should be really knowledgeable. A therapist, in my opinion, should be using evidence-based practices. And you have to kind of resonate with your therapist. You have to be willing to sit and talk to them over the computer or in person for an hour every week, or 2 hours if you're doing a group and that kind of thing. And you have to feel confident in them and that you can actually open up and share things with them. You have to trust them, that type of thing. So here's an example of I'm going to spend the next little while talking a little bit about the example of dialectical behavior therapy and what we do in DBT to help people with BPD, and some of the research that we've done on DBT. So DBT is a comprehensive cognitive behavioral therapy, and it's for clients with complex emotion regulation problems. And so even though it's often related to BPD, DBT is broadening out so that we consider it now a treatment for people in general with emotion regulation problems. So let's see, Lynn, maybe when I start this video, if you could let me know by giving me thumbs up or down whether you can actually hear it, because otherwise I might have to change my audio settings. So I don't know, Lynn, if you could unmute your video and just let me know whether you could hear, whether you could hear that.
Yeah,
that'd be great.
It doesn't work.
Oh, you didn't hear it? Okay.
No.
Let me see if I need to just change my audio settings here. How about now?
Still doesn't work.
Still doesn't work?
Doesn't work.
Oh, okay. All right, well, I'm only gonna give it one more try.
Unfortunately, no.
No, okay, that's all right. Sorry, everybody, Sorry, everybody, it's a good video, but unfortunately you'll have to miss it. But I can tell you what Marcia says. I worked with her for a couple of years and I heard this story before. And the idea is that when she started to develop DBT, what she was trying to do was treat highly suicidal people who were chronically suicidal. She, in her own personal experience, had been chronically suicidal herself, had dealt with all sorts of mental health problems in her youth, had been hospitalized. And so she really was somebody with lived experience, and she wanted to find a way to, in her words, go back into hell and take people out. And so what she wanted to do was find the people in the world who are most miserable. And she reasoned that those people who are most miserable were probably people who were trying to end their lives, and find a treatment that works for them. And so her initial attempt was to use what was out there, which was cognitive and behavioral therapy. And so she started off with that because it had a very firm foundation, lots of research studies showing that it worked. And what she found was that dealing with the complex clients she was dealing with was very different than just doing cognitive behavioral therapy with people with more simple problems, in that they would get mad at their therapists, they would storm out, they would feel invalidated, like somehow the the focus on change in cognitive behavioral therapy, like you've got to change your thoughts, change your behavior, learn new skills, it was kind of like an oversimplification of their problems. It sort of sounded like the message that everybody else was giving them. And if that message worked, their problems would have been better already. And so this idea of you've got to change was experienced as fairly invalidating by the clients. And Marcia didn't realize this was going to be the case. And so over time, she realized that she had to incorporate other things into her therapy, acceptance being one of them, sort of acceptance of the client for who they are, acceptance of the emotions they're feeling, the thoughts they're having, and helping the client accept themselves for who they are, while also helping them change. So for somebody, for example, whose foot is on fire, and you say, boy, looks like that hurts a lot. Yikes. I understand what pain you're in right now. Just being understanding and accepting is probably not going to do the trick. You've got to help the person find a bucket of water and put out the fire. And so going to one extreme or the other just didn't work. Just telling people they have to change didn't work. Just accepting people didn't work. So what she had to do was kind of bring those two together into a treatment that balances acceptance and change. And you might notice in your interactions with your loved ones that you also have to balance acceptance and change. Just telling your teenager that, for example, they need to watch TV less, or they need to spend more time with the family, or they need to do their homework or something like that. Oftentimes, that won't work unless you also include some kind of acceptance, validation of how difficult it is, validation or confirmation that they want something different, that they want to be independent and they want to do other things and that kind of thing. So DBT brings together the best of both worlds, the best of what we know about helping people change behaviors and build a life worth living, but also how to help people accept themselves and who they are, and how to help therapists accept clients for who they are. One way we do this is to make certain assumptions about the clients that we have. And you might think about how these apply to the loved ones that you're dealing with. So clients are doing the best they can. So given the skills that they have, the temperament they have, their backgrounds, right now they're doing the best they can to cope with whatever they're coping with. And at the same time, in order to improve, in order to build a life worth living, they often need to try harder, do better, and be more motivated to change. And so these two would seem not to go together, but if you think of it, they really do. If you actually do have to fly a fighter jet, and you're sitting there and you're doing the best you can, but you don't know how to work all the controls, then you actually do need to do better, and you need to learn new things. The other assumption we make is that clients can't fail in DBT, right? So that if clients don't do well in DBT, it's probably because either DBT wasn't the treatment, or DBT wasn't done the way it was supposed to be done, not because there's something wrong with the client. Therapists can fail, right? So therapists can fail to do DBT, or therapists can choose DBT when it's not the treatment. And then the other thing is that the lives of people with severe problems who are suicidal are often unbearable as they're currently being lived. And so the goal of treatment is to help them build lives that are worth living. The conundrum or challenge that we're in is that to build a life worth living, the client must often take suicide off the table, because if you still are camped out at what I would call the suicide door, you're sort of locked in a dark room and you see a light under a door, and it looks like that's the way out, which is what often people think suicide is. They often think it's the way out, and you're stuck camped out at that door, then you're not looking around for the other doors out, and there are other doors out. And so in order to actually build a life worth living, you have to turn away from the suicide door. You have to sort of take suicide off the table. And to take suicide off the table, you also have to build a life worth living, because why wouldn't you want to kill yourself if your life wasn't worth living? So therapy is not about keeping people on life support and telling them to just be happy with life support. It's actually to help them live a life that's worth living and meaningful to them. So there's different parts of DBT. So one is individual therapy, where the therapist meets with the client 1 hour a week usually. There's telephone consultation, which is the part of therapy where the clinician is available by phone or email or what other method in between therapy sessions specifically to help the client apply the skills they're learning in therapy in their everyday life. There's group skills training, which is once a week for 2 hours, and it involves teaching clients lots of different skills that they can use to sort of help themselves build a life worth living. And then there's the consultation team, which is a team of therapists that all meet together once a week, usually for, depending on how big the team is, for an hour or two. And in some ways, it's like therapy for the therapists, and that the therapists get together and provide each other with support, because it's difficult work sometimes, helping a lot of people who are highly suicidal or who have complex mental health problems. And as loved ones, you're probably intimately familiar with the fact that you can get burnt out quite easily. Some of the skills that are taught to clients and loved ones include the following. So there's mindfulness skills, and if you're familiar with the excellent work that the Sashbear Foundation has been doing, or the National Educational for Alliance in the US, you're probably already familiar with these skills. So there's mindfulness skills, learning how to pay attention to the present moment experience. Distress tolerance skills, learning how to survive crises without making things worse. So when your loved one or when a client has a breakup, for example, what are all the ways that they could make things worse? Well, they could cyber stalk their ex-partner, they could look for pictures with them with their new partner, they could compulsively text them, they could ruminate about things, think about how they were to blame for the relationship going awry. There's all sorts of ways that they could drink, they could self-harm. So the idea is that distress tolerance skills are there to help people avoid making things worse. And the other set of skills are interpersonal effectiveness skills. One of which was my failed attempt to try and not check my bags, right? But there's many better skills than the one that I demonstrated in that particular situation. And then there's emotion regulation skills, which involve pretty much everything under the sun in terms of different ways of identifying, understanding, and managing your emotions. For people who are doing DBT skills group, it goes usually in a 6-month cycle that looks like this. So usually it starts with mindfulness, distress tolerance, or some other skill, and then mindfulness again, and then another set of skills, and then mindfulness again, etc., until they're all done. And the person either graduates because they found that that one cycle of skills was good enough and they learned them and they did their homework, or they might want more. It might be that they learned a lot, but they want to go through them again. And a lot of clients do benefit from going through skills group at least one more time so that they can get traction with the skills. They often find that when they come in, they're distressed and it's harder for them to focus. And once they sort of go through them once, they become familiar with them and are able to hit the ground running the second time around. So is DBT 100% effective? Well, I'll let you read this. So of course I'd be lying if I said DBT was 100% effective, and there's a lot of people, we need to figure out who it is that doesn't benefit from DBT. And there's a lot of people who benefit quite a bit, but there's a subset of people who don't, and we don't understand yet who they are. So we have to do some more research on that. So far, these really smart groups in Australia and in the UK have said that DBT has the most evidence among current treatments for BPD. But people don't absolutely need to have DBT necessarily. They could have other treatments, and other treatments are showing good evidence too. So it's not as if this is the only treatment. And that's another hopeful thing about BPD, is that what we're finding is that structured treatments that focus on emotions, where the therapist is validating and have strategies to manage behaviors that people with BPD engage in, that therapies, if they have those ingredients, tend to be effective for people with BPD. One nice thing about DBT that we're discovering is that it can work fairly quickly. And so I'm going to talk for just a few minutes about a study that we conducted here and in Toronto, where we looked at DBT, all of its components, and we wanted to see whether DBT can be done more quickly than it normally is. So often DBT is a treatment that's usually around 12 months or so, sometimes longer for people and sometimes less. But we wanted to see whether it's possible to get similar effects with a shorter treatment, or at least not worse effects with a shorter treatment. Mainly because the wait lists for DBT programs are really long in the public health system and in private practice. And so we figured that if we were to find out that 6 months is not worse than 12 months of DBT, then that would be a bonus, because a lot of programs could put on a 6-month program and have much shorter wait list for their clients and get a lot more people help. But if it turns out that 12 months is necessary, then that would be another important message to get out, because then people would hopefully be more in favor of funding longer programs, maybe expanding their DBT services. So we wanted to look at the clinical and cost effectiveness of 6 versus 12 months of DBT, and also see which subtypes of patients are less likely to benefit from 6 months. So that second question is not something I will be able to talk about today because we haven't done the analyses yet, but I can talk about the first one, except for the cost effectiveness part. What we guessed was that people in 6 months of DBT would not basically do worse than people in 12 months, either during the treatment phase or during the follow-up period. So our participants were 79% female, and then a variety of other genders as well. Mean age was young adults. You can see the percentage that were married, post-secondary education. And these last two statistics are important based on what I was saying before, that people with BPD have a lot of other disorders as well. And this is what used to be called Axis 1 disorders like depression, anxiety disorders, substance use, and that kind of thing. They had almost 3 on average other disorders of that nature. And they also had a median of about 8 suicide attempts, meaning that 50% of people had more than that and 50% of people had less than that. So this was a sample of fairly high-risk people with serious problems that they were struggling with, many of which wouldn't have gotten treatment if we weren't doing this study and offering it for free. In terms of treatment dropout rates, so when we looked at the 12-month people versus the 6-month people, it was 35% in the 12-month people and 25% in the 6-month people, but this was not a significant difference. So dropout is something that's a big concern for people with BPD, and a lot of studies show fairly high dropout rates. DBT tends to have lower dropout rates because we go to great lengths to keep people in therapy. And so this wasn't a significant difference, and I think the reason that 35 in the 12-month condition versus 25 in the 6-month condition was mainly that people in the 12-month condition just had longer to drop out. In terms of outcomes, I can give you some preliminary data. These are still preliminary because we haven't published the study yet, but people showed a dramatic reduction in self-harm between when they started and around 6 months or so. And it kept declining for a little bit longer and then stayed really low. And there were no significant differences between the 12-month people and the 6-month people, all the way through the study, through the 24-month period, which was 12 months after treatment for the 12-month people and 18 months after treatment for the 6-month people. So basically the bottom line was, really did not look like 6 months of DBT was worse when you consider reducing self-harm. When you look at reducing psychiatric symptoms in general, really no significant differences there, except at the 6-month period, the 6-month people were doing better than the 12-month people, suggesting that they changed faster in their general psychiatric symptoms than the 12-month people did. And then when you look at the borderline personality disorder symptoms, same thing happened. The 6-month people seemed to change faster, and then they kind of converged with the 12-month people later on. And when you take those two together, it looks like for some of our outcomes, 6 months actually resulted in faster changes. And one of the reasons we think that that happened was that people had a deadline, right? They were either assigned to 12 months or 6 months. And when they heard they got 6 months and their therapist heard they got 6 months, they all were thinking, we got a lot of work to do. And it turns out having a deadline actually works. If somebody tells you you're going to have a final exam in 3 weeks versus a final exam in 6 weeks, then how much are you going to study in the first 3 weeks after they tell you? Probably a lot more if you know that your exam's coming up in 3 weeks. And so that's what we think might be happening. And then there's lots of other outcomes here. So for example, social functioning went down significantly in both conditions. Sorry, the little tab at the top keeps popping up, so I can't actually see my full slide here. Okay, anger went down significantly in both conditions with no differences. Interpersonal problems went down, depression, etc. So all the major outcomes went down. with really no significant differences between the 6-month and 12-month people. So bottom line, 6 months seems to work, which is good news for a lot of people. It doesn't seem to be worse than 12 months. It may actually result in more rapid gains on some outcomes. And the gains tend to be maintained at 24 months. And just in my experience, sort of talking to people after they went through the study, a lot of people told me that they really feel like being in the treatment actually put them on a way better path, that they weren't sure that they would have survived if they had not gone into the study and been in the treatment. And for some people in the 6-month condition, even though they sometimes said, well, I wouldn't have minded having more, I felt like I got a lot out of the 6 months that I was in. Another thing to keep in mind is that sometimes treatment in DBT has actually been shown to change areas of the brain that are involved in emotion regulation. So this is another thing that's promising. Set of research has looked at this. I'll just briefly summarize here that the changes in the brain in people with BPD tend to be in areas that are either related to strong emotional responses like the amygdala, or the prefrontal cortex, which is related to the ability to regulate your emotions and your behavior. And so there's some promising research that suggests that not only can DBT happen quickly, but it may actually cause changes in the brain that might help people sort of regulate their emotions much more effectively. So what do we do to help people learn how to regulate emotions? So I'll talk to you very briefly about this before we finish off and I let people have some time for questions. So one of the first steps is to help build awareness. If you're not aware of your emotions, if you can't name them, if you don't know what they feel like, it's going to be very hard to regulate them. Another is to build a strong foundation. So enhancing your self-care so that you can take care of your body in order to take care of your mind. So eating, sleeping, proper nutrition, exercise, avoiding mood-altering substances, those types of things. Checking the facts, so being able to look at the thoughts that you're having that might be contributing to your emotions and being able to sort of check those thoughts against reality. Being able to solve the difficult problems in life that are contributing to misery, the stress at work, the stress with loved ones, other stresses like financial stressors and those types of things, being able to kind of solve those problems so that you have a stronger foundation. Acting opposite. So acting opposite to the emotions that you feel can be a very effective strategy, which I might have time to talk about. And experiencing and accepting your emotions can be another way of managing your emotions. So I'm just going to briefly give you an example of building emotional awareness and the different things that we might help people learn. And this is an example from my own experience. Things, of course, have changed since the COVID pandemic. And so walking rage, okay, is this something that I suffer from that maybe some of you suffer from? This idea of having a lot of strong emotions when you have a hard time getting around people who are going too slowly in front of you. And so in order to help clients learn how to understand their emotions, we might take them through different components of emotions. So there's a situational component, right? So with my walking rage, it might be walking on a busy street, entering or leaving a cafe, store, or restaurant, walking down a hallway or through a doorway, because inevitably there's somebody standing in the doorway. It's unbelievable that people do this, but they do it. They actually stand in doorways. And sometimes more than one person will stand in a doorway. And literally now it's kind of life-threatening to do that kind of thing, because then you have to pass through this sort of vapor vortex and hope that you don't get the virus or something. So I just avoid doorways altogether. But in fact, I've avoided almost everywhere altogether these days. But nevertheless, so the idea of walking down a hallway or a doorway can be a dynamite situation for somebody like me. So that would be understanding the situational component, like the factors in the environment that might trigger an emotion. Then there's the biological component, so facial flushing, sensation of heat, tense jaw and neck, that kind of thing. There's the cognitive component. Okay, so I must admit, sometimes I've gotten a little on the paranoid side, like this person's going slowly on purpose. They must know that they're in my way. Or these days, going in the woods, like for a hike, this runner who's breathing on my neck must know that this is not cool. And so they must be doing it to try and mess me up in some way. course, I know that that's not true, and I've worked on my thoughts, and I'm no longer paranoid about these things. Seriously, you're standing in a doorway, or give me a break. Come on, this is ridiculous. Sometimes the behavioral component might include the urge to physically intervene. I'm sure somebody in the audience has shared this fantasy of just being able to pick people up and move them out of the way. Turns out that's not socially acceptable, and so I haven't done it yet. Walking quickly, darting around, scowling, muttering, that kind of thing. And then often emotions sometimes have an after effect. So what I sometimes call the emotional hangover. So what you feel like after you feel a particular emotion. And that might be agitation or irritation, exhaustion. So it's kind of like what you feel after a strong emotional episode. So these are all different components that are really important to become aware of, because once you're aware of them, there's many roads to Rome. There's lots of different ways of managing your emotions. And oftentimes, if you change one component, you can change them all. So the best way that I found to get around the walking rage is just to walk more slowly and try not to be in a hurry so much. And that's much easier now than it used to be. But what my final frontier is being in the kitchen with my wife, because my wife has this unbelievable, uncanny ability to just sort of be in my way no matter where I am in the kitchen. So like I'm reaching for the cutlery drawer, she materializes in front of me. I'm trying to go into the fridge, she's trying to get the same thing out of the fridge that I'm trying to get. I go in the cupboard, I try to get a cup, she's reaching in for another one. And so she just kind of shows up. And so of course I've worked on this cognitively, I've worked on my thoughts about this. I'm thinking, well, you know, we've been married for like almost 22 years now, at least she's still there. I love her, isn't this wonderful that we get to spend all this wonderful time in the kitchen together? We're so in sync. It looks like we just have the same thing on our minds. We both want a cup at the same time. We both want to go in the fridge at the same time. And then of course the thought will come afterwards, like I just freaking want to get her to get out of the way. But nevertheless, once you know the different components of emotions, you can actually start changing them. So I'm not going to go through this acting opposite because it looks like there's not going to be a whole lot of time for questions, but suffice it to say that oftentimes the best way to change an emotion is to change your action. So a lot of people think they have to think their way out of feeling something, but oftentimes the best way to manage your emotions is actually to take action and do something that affects your emotions. Finally, what can you do? What can we all do? One thing is to listen, try to understand the perspective of the people that we care about who are struggling with serious emotion dysregulation, accept where they're coming from, validate, sort of, and maybe even consider validating before you even make any suggestions or give advice or anything like that. If you are going to give suggestions for a coping skill or for something new or some different way of doing things, you might ask them whether they're open to it first. So what kind of support would help you the most? Would you prefer me to kind of be there for you and just listen to what's happening? Or would you also like me to give you some suggestions? Support, be near. And the other thing, probably the hardest thing to do, I find, with loved ones and with clients, is to both hold on and try to do your best to support and care for them and help them stay on a good path, and to be able to let go and realize that they won't always stay on that path. And that's probably the hardest thing I think that you can do. And I think what I'll do is stop there and thank you all for listening, and we have some time for questions.
Okay, great. Sorry, I just had to find my mute button so that I could unmute myself. Thank you so very much, Alex, for that presentation. I've heard Alex present something very similar to this before, and I never get tired listening to it. There's something new every time. So thank you so much. I'm going to start with one of the questions that comes up repeatedly, and it has come up repeatedly today, which is when your loved one probably has BPD, something similar, maybe they even have the diagnosis, but they resist therapy, treatment. What do you do as a family member to help support them and encourage them to engage in treatment?
Yeah, this is a very good question, and a very one of the most common questions that people will ask. And there's no easy answer to it. If they're resistant to going to therapy, I think the first thing to remember is that it doesn't mean that that will always be the case. And that sometimes if you can kind of gently try to sort of take a stance of, I want to understand what your perspective is on this. Like, what is it that worries you about going to therapy? What is it that concerns you about seeing a professional? This really has to be your decision in order for it to work. So you have to be able to connect with the person. You have to be willing to go. You have to, it has to be a good fit for it to work. And so, and a lot of people don't want to go to a therapist. It's not like a weird thing to not want to go to a therapist. And so I sort of would start with just trying to listen to the person, just sort of gently say, you know, I think from my perspective, I think that there could be some pros, you know, some positives to seeing somebody and getting help. And at least even maybe going in for a first session for an assessment, you know, and then you can sort of ditch it afterwards if you can't stand it. But then moving to like, so what are your thoughts about this? Like, what are your thoughts? What are your concerns? And not coming across, like I found in my work with my clients, as well as my everyday life with my 2 adolescent boys who are at home all the time, nonstop, with no relief in sight. Anyway, I won't get into that. I found that oftentimes letting them feel like they have autonomy, they have the ability to make the decision themselves, and being able to let go for now and then come back to it later on is really helpful. There's of course other tricks that we use as psychologists to get people committed and motivated to things, but that would take a while to train everybody in how to do.
What, you mean you can't just make us all instant experts?
I wish I could. It'd be nice to make myself an instant expert. But no, I think one tip though, one strategy is that I would sort of err on the side of would be the foot in the door technique, which is sort of like asking if they're willing to do one small thing. You know, like for example, look up a local therapist and see what you think. Or maybe another small thing would be going in for a first appointment or an informational meeting on the phone or something like that. So asking for something small and then moving up.
Great, thank you. And as you've mentioned, a lot of these topics are covered in Family Connections, and a lot of people have been asking about that. So I will just mention here that either through Sashbear in Canada or NEA BPD in the United States, that's how you can access the Family Connections program. So I have another question here that's come up quite frequently, and that is how to talk to other family members, especially children, when there's somebody in the family who has BPD, and obviously then the household is dealing with a lot of things. So for a couple of examples are how to talk to teenage siblings of someone who has a diagnosis, or a small child like a 5, 6, 7-year-old who has a parent with BPD.
Yeah, so those are good questions because there's always a balance that you have to strike. So let's say that you have a child who has BPD, and then you've got a younger sibling, and it can be very stressful for the younger sibling because they might be witnessing conflict, they might be hearing about troublesome, you know, worrisome behaviors that the older sibling is engaging in, like self-harm or substance use or conduct problems or other things, and it might be putting stress on them that they're not even communicating to you as a parent. And so and at the same time, you also to a certain degree have to respect the privacy and the autonomy of the loved one who's struggling with BPD. Often people with mental health problems have their autonomy and their privacy stripped from them in various ways. And so it's particularly important for adolescents, as I'm discovering, for them to feel like they're in control of things. And so, you know, one thing might be, one strategy that can be helpful is to talk to for example, your older child about how much they're willing for you to share with other members of the family. Like, what would they like people to know? What would they like people not to know? Ask if they're willing to have a conversation with their younger sibling about things, about like what they're going through in an appropriate way, of course. And sort of being open and asking the younger sibling if they've got questions that they want answered, and conveying, you know, you may not be able to answer all of them, but you're open to listening to them and asking them what kind of support that they need. I find generally people directly asking children or adolescents, like, are you upset about this, or is this bothering you, doesn't usually get the kind of answer that you're looking for. Usually because oftentimes they express their emotions indirectly. So it might be that they're upset, but they're not going to sit down and say, this is how I feel and this is why I'm upset. But you might see it in their behavior. So you might need to notice like changes in their behavior and see whether you can provide some support that will help them, rather than expecting them to always clearly articulate how they're feeling. So those are just a few tips.
Thank you. I think that's very helpful. I'm going to ask one more question, and then maybe Kathleen has one as well. I had a couple of questions come in that are about remission and recovery, or basically the progression of the disorder of BPD. So for example, you mentioned the Zanarini study about, where you're no longer meeting the criteria for diagnosis. And is that sort of a long-term thing? Could a really stressful situation then provoke you to return to a point where you might actually qualify for the diagnosis again? And somebody else asked, they've read that there's a rumor that BPD often fizzles out after the age of 35. So they've heard that it's very much like a young person's disease that you outgrow. So what's the typical progression?
Well, I guess at 45, I don't have to worry about it myself anymore then, huh? So, but, well, the typical progression, I mean, some of the, it's true that there's a fizzling out of some problems over time with age, and some of the problems that fizzle out more are the really sort of crisis behaviors, the behaviors that get people into the hospital or that are very worrisome for other people. So engaging in a lot of suicide attempts or self-injury, outbursts, or really impulsive behavior. So anything that falls under the category of impulsivity generally tends to decline with age. And so that's why we think maybe some of the features of BPD go down with age. We also see that in other disorders that have impulsivity, like antisocial personality disorder. Their sort of reckless behavior tends to go down with age as well. So there's certainly some research that supports that, but it doesn't mean that if somebody's not attempting suicide or hurting themselves or drinking or using drugs, that they're not miserable sometimes, and so that they don't have significant struggles at times. And so it just might be that they're coping with them differently. And then in terms of, if you don't meet criteria for the diagnosis, can things flare up under the right conditions? Most of the studies have looked at people in like 1 or 2 year chunks. So they haven't looked in a fine-grained enough way to see, well, let's say you go through a particular type of stress. Does that mean that you're going to edge back into meeting criteria for BPD? And then maybe once that resolves, you go back out again or something. In my conversations with people, with clients, sometimes it seems to be that that is the case, that they've largely sort of learned new skills, reduced a lot of the behavior that was getting them in trouble, started to build better and more healthy relationships, gotten into a path of a life worth living, and something terrible will happen and it'll feel like a big setback and some of their problems will re-flare up for a little while. But it's important to remember that things that you learn, like if you go through therapy and you learn new skills, things that you learn cannot really be unlearned. And so the pathways that have developed in your brain when you learn new things, those you can always go back to. And so often what I've noticed is that when people experience setbacks, they snap back to getting back on the path to recovery and building a life worth living much more quickly than they used to. And so sometimes it is an up and down road. And like I said before, it doesn't mean that you don't have any problems if you don't have BPD, and you might still have the kind of temperament or characteristics that make you prone to be vulnerable to certain types of stress. But if you learn new things, you will always have those new things, and you can go back to them.
Great. Thank you very much. Kathleen, do you have a question that's come up frequently in the ones that you've been watching that you could ask? And you'll have to unmute yourself. I'm not even sure if you're there because I know your connection dropped a moment ago. Okay, so maybe oh, great.
Oh, looks like she's there.
I'm kind of here. And to make sure I stay connected, sorry. One of the questions that has come up a couple of times, and it's regarding treatment, is DBT the same as CBT?
Yeah, good question. So DBT is similar. It's you could sort of consider it a form of CBT. And in some ways, it's a really big sort of comprehensive form of CBT because it includes individual therapy, skills training, phone coaching between sessions, the therapist consultation team. And so it's kind of like if you think of CBT as like a bow and arrow, oftentimes CBT is very focused and very good at solving particular problems like panic disorder or depression or those types of things. So CBT is like a bow and arrow, and DBT is like a shotgun. And so it's a bigger treatment. It's more comprehensive, generally speaking, than most forms of CBT. And it also more explicitly includes this idea of balancing acceptance and change. So there's a lot more focus on how to be really effective in validating clients, validating where they're coming from. And there's more of a focus on emotions. So in DBT than there is in standard CBT. So much more focus on helping people understand and regulate their emotions, because what we think of is the core of the problem is emotion dysregulation. So it's got lots of similarities. And even Marshall Linehan has often said, you know, I kind of looked up the best treatments that were out there, and that's where all my skills came from. I just sort of went through other people's treatment manuals, and a lot of them were CBT, and came up with skills. And then a lot of them are sort of new and different as well. But they're very similar to CBT.
Okay, and related to that question, I have, what if taking DBT for 12 weeks, one realized it didn't work? What's next? So my question to follow up with that one would be, is there a time frame to go through DBT therapy for it to be effective?
Yeah, so that's a good question. It sort of gets at the idea of like, when do you know that you're not responding to DBT? So like if you go for 12 weeks or 16 weeks or something and you're not noticing noticeable changes in your life, does that mean that it's not likely to work for you, or is it worth hanging in there for longer to see if it will work? We don't know enough to know whether that's the case. We do know that with self-harm behaviors like suicidal behavior and self-injury, that usually most of the change happens in the first 4 to 6 months or so. And so a lot of people will notice big changes in the first 4 to 6 months. That doesn't mean that if you don't notice those changes, that you won't later on. But it might be that if you're not noticing changes in those behaviors in the first 4 to 6 months with your therapist, maybe you're not on target as well as you could be. Maybe you need to work with that person to figure out really what is it that's keeping you engaging in these behaviors. Similar with other problems like reducing anger problems or interpersonal problems. If you're not noticing the kinds of changes you'd like to see, and you're in therapy, I would highly recommend that you work collaboratively with your therapist to figure out what you're both missing and what is it that could be changed or improved, or is it a different therapy, a different therapist, that kind of thing. So I don't think we know enough to say that, well, if you haven't responded by this time, you're not likely to respond. But the longer you go and without noticing the types of changes in goals that are really important to you, the better it is to sort of say, hey, wait a sec, let's figure out whether we can make some changes. And therapists are ethically obliged to do that as well. If they notice, what I'll normally tell my clients is that about every 3 months or so, we're going to kind of look at where you are, how therapy is working. And I mean, we sort of do it every week too, because people are keeping track of things every week, but we do it sort of more formally every few months, and then see whether there's anything we need to change to improve things.
Okay, thank you.
Wonderful. So thank you so much, Alex. We're going to wrap up here because I know that you have to go, and you mentioned you have to go prepare dinner for your family. So we want to allow you to go, and thank you so very much for having spent this amount of time with us answering questions. Once we've had a chance to clean up the recording, we will be posting it on the Sashbear website. So that's www.sashbear.org. We actually have some other webinars already posted there, and a lot of the questions came up around trauma, PTSD, overlap and treatment of those co-occurring conditions. And we do have a webinar on the website already by Dr. Skye Fitzpatrick, whose research is into treatment on trauma as it overlaps with BPD. So I would encourage you all to go look at that. And we'll try and get some answers out to a few of you from some of the questions that are still outstanding. So once again, thank you so much for joining us, everybody who's been listening, and especially Dr. Chapman. Thank you for sharing your insights and your expertise with all of us.
My pleasure. Good to talk with you all. Take care.